Welcome back, students. In this module, I am going to talk about some of the important anesthetic emergencies. Anesthetic emergencies or complications occur very rarely, and they occur very rarely whenever anesthetist is alert. But if and when they occur, as said earlier, anesthetist has to be awake and alert, and he has to diagnose those particular complications as quickly as possible and treat them as precisely as possible. Because if anesthetist is not alert and if he does not diagnose those emergencies in time, the only complication, as I always mention, is death and nothing else. So, following anesthetic emergencies, I am going to talk in detail about. First of all, I am going to talk about difficult intubation. Intubation forms mainstay of anesthesia practice, and every now and then, any anesthetist who is in clinical practice encounters this particular problem of difficult intubation. I'm going to talk in detail about this, how to counter it, and what is the difficult intubation drill which every anesthetist must follow or every doctor must follow, so that patient may be intubated in time and thus life of the patient could be saved. Then second form of emergency is can't intubate and can't ventilate. This is a dire emergency with 100% fatality rate if not treated properly and if surgical help is not summoned at an appropriate time. In spite of doing all the techniques, using all the modern methods available, if a person or a patient is not being able to be intubated, neither can he be ventilated with the help of with the help of bag and mask ventilation, this life-threatening situation arises. This is called can't intubate, can't ventilate. Then I am going to talk about severe laryngospasm, air or gas embolism. I am going to talk about aspiration, malignant hyperthermia. This is also one of the forms of anesthetic emergencies. How to tackle this, anaphylaxis, general management, and also I am going to talk in detail about unsuccessful reversal of neuromuscular blockade. I have just these emergencies which I have mentioned are just some of the emergencies, because anesthetic emergencies never tell you that at this particular time an emergency has occurred. You have to diagnose it. It can occur anytime. You have to diagnose it and treat it appropriately as per the needs of the patient. Now let's talk about difficult intubation. Just have a look at your screen. A quarter of preventable deaths related to anesthesia are basically due to airway mismanagement. Hence, proper endotracheal intubation forms the mainstay of airway management. As I said earlier, endotracheal intubation forms the mainstay of anesthesia practice, and every anesthetist in this world has to know how to manage a difficult intubation. So, as mentioned over here, quarter of the preventable deaths related to anesthesia are due to mismanagement of airway, and they could be proper if you follow this particular difficult intubation drill which I am about to talk to you. Difficult intubation can be grouped into two types, that is, first when it is anticipated and second when it is unanticipated. Anticipated difficult intubation can be seen in elective surgical cases when anesthetist goes for preoperative evaluation and checks for all the signs and examines the patient with mouth opening, spine examination and others. He comes to a diagnosis that this particular patient may have difficult intubation, and this type of difficult intubation is called an anticipated difficult intubation. Whenever anesthetist comes across this type of anticipated difficult intubation, he is prepared with various tools including laryngoscopes, newer laryngoscopes, fibrooptic laryngoscopes, fibroscopes. Also, he is prepared with assistant who are trained for this particular difficult intubation drill. But second and major form or complicated form of difficult intubation is unanticipated difficult intubation. This mostly occurs in emergency cases when an anesthetist is not prepared for a difficult intubation, and when suddenly such a situation arises, the mainstay of treatment is for an anesthetist has to be calm and patient, because if he loses the cool, it is 100% sure that patient will not be able to intubate the patient. So the main thing which I have been taught by my seniors and by my professors, whenever an emergency occurs, anesthetist has to remain as cool as possible, diagnose the problem and treat it as efficiently as possible. Now talking about anticipated difficult intubation, in preoperative evaluation, as I said, you have to check for mouth opening, including dental status, missing teeth, prosthesis, look for neck movement, range of the movements, whether it is more than 90 degree or less than 90 degree. This have been talked before in previous module in preoperative evaluation. Also look for any swelling over the neck palpation, examination of nose, any nasal problems, nasal polyps, because these all things add up together and ultimately can lead to difficult intubation. Now what are the signs of difficult intubation? First, trauma, deformity, burns, radiations. Any form of trauma, including over head face neck, deformity of head face neck, burns, accidental burns of head face neck, can render a person who is otherwise very easy to intubate, but because of these problems like deformity, trauma, burns and radiation, a normal person could be rendered a person for a case for a difficult intubation because of these things. Also, look for stridor or hair hunger. This shows respiratory. Patient is having some respiratory discomfort leading to this stridor and hair hunger. Look for any mandibular abnormality such as fracture mandible. Look for interincisor gap. It should always be more than 3 fingers. If it is less than 3 fingers, you can anticipate a difficult intubation. Look for high arched palate or oropharynx, any evidence of protruding teeth, neck abnormalities like short neck or webbed neck, trauma to the neck, any tumor present on the neck. These are all signs which may lead to difficult intubation. When you go for preoperative evaluation, these are all signs you should always check for. In the head face neck, in thorax, you should always look for breast size extensively large. If the breasts are extensively large, they can cause pressure on the thorax, may lead normal intubation and change it to a difficult intubation. Also, evidence of any kyphoscoliosis, near-term pregnancy, Mallampatti classifications of grade 3 and grade 4. These are all signs of anticipated difficult intubation. And whenever during preoperative evaluation you come across these signs, you anticipate that this type of intubation is going to be a difficult intubation and be prepared for additional tools, additional methods, assistance so as to counter this problem. And this type of problem, if and when countered, comes under the heading of anticipated difficult intubation. What are the tests you should carry out? Mallampatti classification. This has been discussed in detail in previous module. Mallampatti classification, as I said, thyromental distance, interincisor gap, Wilson's rule and radiological evidence. All these tests have already been talked in preoperative evaluation. Now how do you grade difficult intubation? Grade 1, it has been graded into 4 grades, like grade 1 to grade 4. Grade 1, when there is no external pressure required on cricoid cartilage during intubation. This type of intubation is called grade 1 or no difficulty intubation. Grade 2, when external pressure is required on cricoid cartilage so that the cords are pushed downwards so that it could be easily visualized during laryngoscopy. Grade 3, this form of difficult intubation in which, in spite of presence of cricoid pressure, cords are not visualized and use of stillate is required so as to intubate the patient. And grade 4, this type of intubation or failed intubation, in spite of using stillate, in spite of using boogies, anesthetist is not able to intubate the patient. This is called grade 4 or difficult intubation. Thus, difficult intubation have been graded into 4 categories. Grade 1, with ease of which, without any external help, patient could be intubated. Grade 2, with the help of cricoid cartilage, patient could be intubated. In grade 3, with the help of stillate, patient could be intubated. And grade 4, where in spite of using stillate, in spite of using cricoid cartilage, in spite of using any other surgical help or any other help by assistant, intubation is not possible. Thus, you grade it as grade 4 difficult intubation. Now, what are the accessories you require when you anticipate a difficult intubation? You may require additional tools in addition to various blades available with the laryngoscope. You require gum elastic bougies. A flexi tip may be handy so that you are able to lift the glottis, so that you can visualize the cord flexi-tip as I have shown already in previous module. Stylettes, various forms of stylettes are available in the market, so that you can intubate the cord with the help of stylet and just pass on the endotracheal tube over the stylet. There are malleable stylet which are recently available. Some of the malleable stylet also have a light source at the tip of it, so that even without laryngoscopy, just by passing the stylet, with the help of stylet, you can intubate the cords. Some of the combi tubes are available with which you can intubate the cords. Even if you are not inside, you cannot visualize the cord, combi tubes easily pass. One of the tube gets fixed in the esophagus, and the other tube readily passes the cords, vocal cords, and thus you are able to intubate the patient. Fiber-optic laryngoscope, it is the most recent advance in the field of laryngoscopy, with the help of which you can intubate any type of difficult intubation. And in spite of using all these accessories, if you are not able to intubate the patient, then cricothyroidomy set, this forms the mainstay of intubation or the life-saving tool. I am going to talk about cricothyroidomy in detail as we progress, because this is the life-saving tool. If at all a patient is not being able to intubate in spite of all the recent advances, in spite of all the recent tools, this is very small cricothyroidomy state which is available in market, with which you can save the life of patient. And this type of tool or cricothyroidomy state should always be present in the anesthetist bag, as it is the most life-saving tool available till date. Now I am going to talk in detail about difficult intubation approach or difficult intubation drill. What a surgeon or an anesthetist or a doctor is supposed to do whenever he encounters this anticipated difficult intubation. First and foremost, taking all routine care, patient is being anesthetized, it is being induced. Taking all routine care, when you are anticipating a difficult intubation, you are preparing the patient with all the preparing yourself, the anesthetist, with all the necessary tools. Assistants are available, and then after induction you start and go for intubation. And following things, how you approach the drill. Now, after doing laryngoscopy, if glottic opening is not being visualized, you ask the assistant to maintain cricoid. As soon as ask the assistant to maintain the cricoid and do direct laryngoscopy once again. See if you can see the cords. In spite of that, if cords are not seen, you summon help. Ask the surgeon or assistant, operation theatre assistant or staff nurse, so that they can help you. Repeat tracheal intubation with optimal head position. Suction, do oral and nasal suction of pharynx. Use a smaller tube and decrease the cricoid pressure. See if you can visualize the cord. In spite of doing all this, if you are not able to intubate the patient, after doing all this, you can divide this particular thing into two types. Whether you are able to do intubation with all these maneuvers, that is summoning help, using lesser tube, repeating laryngoscopy, doing oral and nasal suction. If it is successful, then you continue giving anesthesia and continue the surgery. If at all, in spite of doing all this, if the intubation is not done or intubation is not successful, then you divide the patient into three types. You first then use some recent advances or recent tools that are available. Repeat the laryngoscopy with fiber optic laryngoscope and repeat the intubation with bougies. And if still after using all the recent advances intubation is unsuccessful, then you divide the situation into three types. Whether in this particular situation ventilation is possible, ventilation is not possible, and if at all ventilation is possible, is the surgery elective or is the surgery emergency? You can have a look at your slide. You can always see, if at all, in spite of doing all the tools, if the intubation is not possible, and if the patient you are able to ventilate the patient with the help of bag and mask, then, and if the surgery is elective, then maintain the cricoid, try to awaken the patient, reverse the patient, get him out of anesthesia, and post the patient at a later date or use a regional anesthesia technique. This is possible because you are doing the surgery for an elective cause. If the surgery is emergency, you don't have the choice, but you have to continue with the case. In that case, you maintain the cricoid, add additional agents, and maintain the patient spontaneously. That is, give the patient general anesthesia with spontaneous respiration. But while doing that, you should always be cautious that patient does not aspirate and patient maintains his oxygen saturation. The second situation which I talked about, if ventilation is impossible even after maintaining cricoid, then you don't leave any choice. If patient is, we are not able to ventilate in spite of doing all the thing, and also you are not able to intubate the patient. It leads to a situation where you are not able to intubate, and can't ventilate. In this situation, maintain the cricoid, maintain the airway with the help of airways or LMAs, and then ask surgical help, go for cricothyroidomy or tracheostomy. These are the two ways by which you can save the life of patient. Thus, difficult intubation drill, I will just repeat it once again for you. If while doing laryngoscopy, direct laryngoscopy, glottic opening is not visualized, maintain cricoid, summon help, do oral and nasal suction, repeat tracheal intubation with optimal head position, use a smaller tube, decreased cricoid pressure. If still you are not able to intubate the patient, use recent advances, recent tools like gum elastic bougies, fiber optic laryngoscope, and see if cords are visualized. If at all after doing all this, the intubation is successful, well and good, you can continue and go ahead with the surgery. If after doing this, still intubation is unsuccessful, you grade the patient into two categories, whether ventilation is possible or whether ventilation is not possible. If ventilation is possible, you again divide the patient into two categories, whether ventilation is possible and surgery is elective case. If the surgery is elective and surgery need not be done immediately, then try to reverse the patient, awaken the patient, post the patient for surgery at a later date, and preferably choose a regional anesthesia technique. If at all the surgery is emergency and ventilation is possible, you don't have choice, you are left with no choice but to go ahead with the surgery, maintain the cricoid, add additional agents, and maintain the patient with spontaneous respiration. But take care that you maintain SpO2 of the patient and see to it that patient does not aspirate. Use preferably a LAMA or laryngeal mask airway so that spontaneous respiration is well maintained. However, let's talk about the second scenario in which ventilation is impossible. In this case, you are landing up in a life-threatening situation where ventilation is impossible. You cannot intubate and cannot ventilate. In this case, you don't have a choice. Maintain the cricoid, maintain the airways, ask for surgical help. If cricothyroidomy set is available, use it instantaneously to save the life. And if that is not available, ask surgical help and go for tracheostomy, as tracheostomy in this case will be life-saving situation. Now going back to second emergency, that is can't intubate, can't ventilate. Just as I mentioned, this is a life-threatening situation. If managed badly, it will lead to 100% fatality. Management in this case, insertion of laryngeal mask airway or LAMA is a must to maintain the airway of the patient. This is followed by following things. Keep LAMA in situ to provide route for exhaled air, inject ventilation. Go for emergency cricothyroidomy. Surgical intervention. Ask for surgical intervention if progressive desaturation. Because even after doing cricothyroidomy, or if cricothyroidomy is difficult, then ask surgical help if progressive desaturation is done, because patient may desaturate very rapidly and it's a life-threatening situation. You have to act very, very quickly. And the ultimate treatment in can't intubate, can't ventilate is nothing but tracheostomy. Just as I mentioned earlier, this is a life-saving procedure which can be done with the help of surgeon, or if an anesthetist is confident to do that, do it and save the life of patient. Now let's talk about third emergency, that is severe laryngospasm. This is often encountered during your clinical practice. I have encountered severe laryngospasm around 3 to 4 times in my clinical practice. What are the risk factors for severe laryngospasms? Following are the risk factors which I have listed. Please have a look at your slide. barbiturate induction or light anesthesia. Whenever induction of anesthesia is done by barbiturates, or the depth of anesthesia is low, and when intensive surgical stimulus is done at this particular stage, this may lead to severe laryngospasm. For example, if anal stretching is done on a patient who is not deeply anesthetized, this can lead to severe laryngospasm. Extubation of a soiled airway can lead to laryngospasm. Thyroid surgery, thyroid surgery is a risk factor for severe laryngospasm. Any foreign body inhalation may lead to severe laryngospasm, and hypocalcemia. This is also one of the mainstay for cause of severe laryngospasm. So just as I mentioned, just to repeat, what are the risk factors for severe laryngospasm? Barbiturate induction or light anesthesia, that is depth of anesthesia is low, intense surgical stimulus as in case of anal stretching, extubation of soiled airway, thyroid surgeries, foreign body aspiration, or hypocalcemia. These are the causes which may lead to severe laryngospasm. And what is the immediate management? Remove the stimulus. As soon as you encounter a case of severe laryngospasm, you have to judge what is the cause, diagnose the cause, and remove the stimulus immediately. Just as if you see, if the intense surgical stimulus is the cause, or thyroid surgery or foreign body inhalation is the cause, immediately remove the cause. This is the mainstay in treatment of severe laryngospasm. Clear the airway, do complete oral, nasal and pharyngeal suction. Then fit a tight fitting mask with high concentration FiO2, so that you give 100% oxygen at a fast pressure, so that if at all laryngospas is there, it can be cured with the help of jet airway ventilation. And this can be continued at a later stage with CPAP or continuous positive airway pressure. If during induction severe laryngospasm occurs, consider deepening anesthesia. Injection Scoline should be given immediately, and intubate the patient and ventilate the patient. Because injection Scoline, as soon as you give this depolarizing muscle relaxant or injection Scoline, it relaxes the cords, and laryngospasm from whatever the cause gets cured by itself. But after giving muscle relaxant, you are supposed to intubate the patient, because patient will not be able to breathe on his own. Intubate and ventilate the patient, subsequently manage the cause, and then during doing this, always monitor pulmonary edema, and always insert an orogastric tube so that you empty the gastric contents, so that it does not cause aspiration at a later stage. Now talking about the next complication, it is air or gas embolism. What are the risk factors involved in it? Following are the risk factors, like spontaneous ventilation with patent foramen oval. This is a major cause of air or gas embolism. And air or gas embolism, as you all know, is a life-threatening situation. If not treated properly and if not cured properly, there is no other complication than death. Because in this case, if you do not remove the embolism, ultimately what it does, it just obstructs your blood flow to the major organs, as a result of which death is the only treatment. And it is very difficult to diagnose air or gas embolism. You should be very alert and confident that this is the cause. Once you know the cause, you have to treat adequately and immediately, so that no further disturbances occurs in the major respiratory or cardiovascular system of the patient. Coming back to air or gas embolism, the risk factors are spontaneous ventilation in a patient with patent foramen oval, which is a congenital abnormality, hypovolemia, or operative site which is present above the level of the heart. This can lead to air or gas embolism. Severe orthopedic surgeries are the major cause of air or gas embolism, because the large surface area has been exposed during orthopedic surgeries, and also large number of venules are exposed. So air get easily access through these open venules and can lead to air or gas embolism. Multiple trauma or polytrauma, where a large surface area of body is exposed, can lead to air or gas embolism. Laparoscopic surgeries form one of the mainstay of air or gas embolism. Also posterior fossa surgeries, which occur in neurological cases can lead to air or gas embolism. So, highlighting the main risk factors, again, spontaneous ventilation with patent foramen oval, hypovolemia, orthopedic surgeries, polytrauma, posterior fossa operation, laparoscopic surgeries, or middle eye surgeries are the risk factors for air or gas embolism. How do you diagnose air or gas embolism? There is sudden fall in SpO2 and EtCO2 trace on capnograph. This is the major diagnostic tool by which you can diagnose air or gas embolism. Suddenly there will be fall in SpO2 and EtCO2. There will be sudden tachycardia. If patient is awake, he will experience severe chest pain, sudden rise in CVP or central venous pressure. ECG shows ST segment depression, and even with 0.5 ml per kg per minute IV gas. Any gas, if it gets access inside the vein, only about 0.5 ml per kg per minute of IV gas can lead to these symptoms. That is fall in SpO2, EtCO2 trace on capnograph, severe tachycardia. If patient is awake, he will have severe chest pain and sudden rise in CVP. And ECG will always show ST segment depression. So this is how you are supposed to diagnose air and gas embolism. How do you treat air and gas embolism? I will talk about this in next module. Thank you.